my name is Shawndra Ferrell, and I am the Inpatient Palliative Care Program Lead at Advocate Aurora Health's Trinity Hospital on the southeast side of Chicago. Besides being a nurse practitioner, I am also a minister and a parish/faith community nurse. The palliative care program that I am building is just under 2 years old, actually. And as a solo provider, one of the first things that I started to notice in my patient population was that I was having difficulties in certain conversations. Now, the total service area around Trinity is about 83% African American, but my problem was not necessarily with specifically African Americans, it was with people of faith, any people of faith. And so it is a lesser known barrier, but African Americans do place a very high regard on keeping their healthcare decisions in line with their religious practices. And so I did start inviting, with their permission, I started inviting patients, pastors, and faith leaders to the advanced care planning and goals of care meetings. They always appreciated it. They always wanted more information and wanted to know how we could do this in the community. It just so happened that at the same time that I was building the program, I was also in a doctoral program. And so I stopped everything right there, changed my whole project, and started to figure out how could I get my project to the people. So I used the IHI, the Conversation Project, more specifically the Conversation Ready Toolkit. And the toolkit is evidence-based, it's free, it's downloadable, it's customizable to any organization that wishes to use it. And they have faith-based specific tools that anybody can use. One of their mottos is, it's always too soon until it's too late. And then they often pose the question, what does it mean for an organization to be conversation ready? In their own research, they did find that 90% of people do believe we should have the conversations, but only 30% of people do. So using a pastor and his members, he designated as leaders, then I built a program where we would do 2 sessions. The first session, I would teach them what advanced care planning is. The second session, I would teach them how to teach it. So there were 5 hours each of 2 Saturdays. They were provided with a light breakfast, a full lunch, and each person received a $25 gift card at the end of each session. So they received a total of 4 hours of instruction on each Saturday. The week before the leader's intervention, the pastor also received an abridged version of what they were taught. So the findings were actually very, very encouraging. The leaders' surveys were self-reported via a Likert scale from 1 to 5, and I was looking for attitude changes, specifically readiness and self-efficacy or confidence. So the project was, like I said, very successful in that both readiness and self-efficacy showed a significant change, specifically an increase across all 3 time points, which were pre-test, post-test 1, and post-test 2. So the limitations of the project were this. It's not generalizable because there is a small sample size. That size is gonna look different if you try to repeat this in a larger organization or a mega church of some sort. Also, whatever the religion is, the denomination behind that particular faith base, and even ethnicity is gonna make a difference. Also, I did use paper surveys. It created just a small problem in the sense that on paper, they're able to not just stick with the questions you provide, but write in answers. So you'll notice that my participant numbers change based on different time points, and that is why. So my conclusion and my takeaways, in any faith community, most of the work will be with the lay workers. You will need an in with the pastors, but because of the senior leaders' workload, your work is going to be with the lay workers, but you must always include the faith leader. You cannot impact a faith community unless you influence the faith leader, okay? When communicating with people who have trust barriers. it's not sustainable programming if they can't do it without you, okay? And it's interesting that I completed this project in February of 2020 because COVID hit Chicago very hard in March. So immediately after, so there's some opportunity to follow up with these leaders and find out, how did this affect them? When they heard the words CPR, DNR, or ventilator on the news or in social media, did anything change in their lives? Did they have these conversations in their homes with their families or in their small quarantine communities? And then finally, my mind imagines, what could happen in my emergency room in the next 5 or 10 years if every church, if every mosque, if every synagogue in a 5 to 10 mile radius started doing these kind of projects. What would the patients look like? So ultimately, I believe that there doesn't need to be a battle between medicine and miracle. And if we work hard, we can help people to just involve their faith experience and their health experience. And that is essentially what I hope to do. So I thank you very much for your time, and I appreciate your interest in this project.
Hello, everyone. My name is Torre. I'm the Director of Palliative Care Inpatient Service at Stony Brook Hospital in Long Island, New York. And I'm here to present my poster on how to address barriers to language access during the COVID pandemic. Since the beginning of the COVID pandemic, many healthcare systems have struggled with providing effective communication among patients, their families, and healthcare providers while maintaining the safety of all, including the staff. The protective measures that were put in place to achieve this have led to various degrees of patient isolation, family isolation, as well as limited access to in-person interpreters for patients with low English proficiency or non-speaking English patients. Here at our tertiary academic center in Long Island, we recognized pretty early on in the pandemic that we were experiencing a high influx of Spanish-speaking patients coming to be screened not only in our emergency room and our triage areas, but also patients who were being admitted with the disease. We knew that we had to put into place many strategies to accomplish, to be able to address this and be able to provide the best care for this patient population. The strategies encompass multiple things, including education as well as access to virtual interpreters. The education was specifically related to educating our colleagues in the impact of lack of language access, as well as them being able to recognize patients who require interpreters. We collaborated with some other departments here in the hospital, including the nursing department, the patient experience department, and our information technology department. We also acknowledged that we did not have enough devices to quickly be able to provide to all our patients who are here in the hospital in order to facilitate in an effective and quick manner access to virtual interpreters. So at a hospital level, we decided to initiate a tablet drive, and reach out to our community to accomplish this. And we did this via social media and other avenues. We were able to collect over 400 tablets. The information technology department helped us get these tablets ready, get the apps for virtual interpreters ready, and quickly disseminate them for patient usage. We also recognize that teams and providers and the staff in general needed to be educated on how to utilize virtual interpreters, which in the past we had not had to use until COVID happened. So we, again, collaborated with the patient experience department as well as the IT department to make sure that everyone using this tablets felt comfortable enough accessing virtual interpreters. Furthermore, the palliative care service as well played an important role in recognizing need for interpreters. We were screening all patients who were high risk for COVID, who were high risk for morbidity and mortality on admission. And this allowed us to also recognize those patients who needed virtual interpreters. We were able to provide them tablets pretty quickly, as well as support the other primary teams caring for them and how to utilize them. We were able to provide over 150 patients with virtual interpreter encounters during the height of the pandemic. The palliative care service actually conducted over 50 goals of care conversations using virtual interpreters. We furthermore recruited in-person volunteers to interpret in high influx areas such as the emergency room and the triage areas, as we knew that really having an in-person interpreter was essential. And we did this through accessing volunteers from the university and specifically the language department. Lastly, what I want to say is literature has shown the importance of adequate language access for all patients, especially those with serious illness, in order to provide appropriate care. The COVID pandemic has highlighted how the lack of effective language access can lead to poor patient outcome. The strategies that I've discussed in this poster definitely have helped ensure language interpreter access, while at the same time allowing healthcare providers feel comfortable utilizing interpreters, specifically virtual interpreters, while providing best care during a high stress circumstance such as the pandemic. I hope this was helpful, and thank you again for having me.